Welcome, everyone. I'm excited to welcome you to this important event. Today, we'll be discussing the National Training of Trainers on AI-powered CXR systems rollout. The dates are July 28 to 30, 2025, and we're gathering here in Bishoftu. The focus of our session is the operational manual highlights for AI-powered CXR systems used in TB detection across Ethiopia. Over the next few days, we'll cover key aspects of these innovative systems, how they're being implemented, and their role in improving TB diagnosis. I look forward to an engaging and productive session with all of you. Let's delve into the background of our presentation. We'll explore the scope and purpose of the National Operational Manual, which serves as a guiding document for implementing TB detection strategies. We'll also look at how AACXR systems can be utilized for TB detection, considering both global and national policy recommendations that support their use. Moving forward, we'll review the recommended AACXR-based TB screening algorithms specific to Ethiopia, tailored to local needs and contexts. Next, we'll provide an overview of AACXR systems, highlighting how they function and their role in screening processes. Understanding how to interpret the CAD output and confidence scores is critical. These help us assess the reliability of the AI's findings. We'll also discuss interim CAD thresholds set in Ethiopia, which are used to guide decision-making during the initial implementation phase. Then, we'll look at the workflow involved and how to effectively integrate AACXR systems into clinical decision-making, ensuring seamless operation within existing health services. We'll cover the steps for setting up and operating the system efficiently, emphasizing best practices. Finally, we'll touch on the monitoring and evaluation system, an essential component to track performance, improve processes, and ensure the system's sustainability. All these points tie into our overall goal, improving TB detection through innovative, technology-driven approaches aligned with national health strategies. Tuberculosis remains the leading cause of death among infectious diseases worldwide. It's a significant public health challenge that we can't ignore. Ethiopia, in particular, is among the 30 countries with the highest TB and TB-HIV burdens. The estimated incidence rate in our country is about 146 cases per 100,000 population, which highlights how widespread the issue is. However, a large number of TB cases are being missed each year, meaning many people with the disease remain undiagnosed and untreated. This gap underscores the importance of improving our detection methods. That's why the TB-LLD NSB 2023 to 2030 emphasizes implementing high-impact, evidence-based case-finding strategies. One of the key approaches is the use of highly sensitive screening tools, such as AI-powered chest X-ray systems. Our national guidelines have been revised to recommend these advanced tools as the primary screening method, especially for high-risk groups, key populations, and vulnerable communities. This shift aims to catch cases early and ensure more people get the treatment they need, ultimately helping us control and reduce TB's impact in our country. This slide highlights a crucial part of our efforts in Ethiopia's fight against TB. It's an integral component of the 8th edition of our national guidelines for the clinical and programmatic management of TB-LLD. What this means is that it provides practical, easy-to-follow guidance to help us implement AI-powered chest X-ray systems for TB detection across the country. The goal here is to support our health workers, program managers, policymakers, and all partners involved in TB control. We want to make sure everyone understands how to adopt and seamlessly integrate this innovative technology into our national TB response efforts. Importantly, this manual aligns with Ethiopia's broader strategic frameworks, like the TB-LLD National Strategic Plan, the Health Management Information System Development Plan, and our digital health strategy. Think of this manual as a roadmap, guiding us on how to incorporate AI tools into TB detection pathways at different levels of our health system. It's about creating a cohesive, integrated approach that strengthens our overall response and improves outcomes. Ultimately, this operational manual serves to clarify the scope and purpose of these efforts, making sure everyone is on the same page and moving forward together. In 2021, the World Health Organization recognized that for individuals aged 15 and older, especially in populations where TB screening is recommended, computer-aided detection software, or CAD programs, could be used instead of human readers to interpret digital chest X-rays. This was a significant step forward in streamlining TB screening processes. Moving to 2025, the WHO has set clear policy standards to ensure the effectiveness of these CAD tools. Several programs, including CAD for TB version 7, DoctorAid for TB screening version 244-6, Genki Edge version 342, Infuri Doctor Chest version 1011, Insight CXR version 3.1, and QXR version 4, have met the WHO's performance benchmarks for community and facility-based screening in people 15 years and older. However, not all CAD software has reached this standard. For example, JVIEWERX version 500 and Ratify Chest version 380 did not meet the WHO's criteria for effective use in these settings. This highlights the importance of selecting validated tools that meet global standards. The WHO's recommendations emphasize the role of AI-powered chest X-ray systems as a valuable component in TB detection efforts, especially where access to expert radiologists may be limited. These advancements are crucial in our overall goal to improve early detection and treatment of TB worldwide. Now, let's focus on the importance of systematic TB screening. It is strongly recommended to screen specific groups who are at higher risk. For example, household contacts of TB patients need to be prioritized because they are exposed regularly and have a higher chance of infection. Next, we have people living with HIV, including those who are on antiretroviral therapy, as they are more susceptible to developing active TB disease. Minors and individuals exposed to silica dust are also important groups to consider, given their increased vulnerability. Prisoners represent another high-risk group because of the crowded conditions and limited access to health care. These recommendations are in line with WHO guidelines, emphasizing a systematic approach to screening. Overall, the goal is to identify and treat TB early in these vulnerable populations to reduce transmission and improve health outcomes. By focusing on these groups systematically, we can make a significant impact in controlling TB within our communities. Slide 7 highlights some important aspects of using chest X-ray as a screening tool for TB. While it is less sensitive compared to other methods, it is still highly specific, meaning that when it does identify someone as having TB, that result is quite reliable. However, because it's not perfect, a follow-up test is usually needed to confirm the diagnosis. One of the key strengths of chest X-ray is its high sensitivity for detecting TB disease, even before symptoms appear. This allows for earlier detection, which is crucial in controlling the spread of TB. For adults over 15 years old, computer-aided detection systems, or CAD, have been approved to interpret chest X-rays, replacing the need for a human reader. This makes the process more feasible and easier to implement, especially in settings with limited resources. CAD systems require relatively low resources, making them accessible in many different environments. However, it's important to remember that no screening tool is perfect. Chest X-ray does not detect everyone who has TB, and it's not highly accurate on its own. That's why we often combine it with rapid molecular tests or symptom screening, which includes asking about cough and other symptoms. Overall, when selecting tools for screening individuals over 15, we need to consider their strengths and limitations, aiming for a practical approach that can be widely implemented to catch TB early. Let's talk about rapid molecular tests. These are a powerful tool because they can be used to screen all people living with HIV, helping us identify infections quickly and accurately. They are especially strongly recommended for acutely ill and hospitalized patients, as part of a test and treat strategy. This means we can directly use the test results to guide immediate treatment decisions, which can be critical for patient outcomes. Next, we have chest X-ray combined with computer-aided detection, or CAD. This combination improves the sensitivity of screening, especially for those who are already in regular art care. It's important to note that CAD is only recommended for individuals aged 15 years and older to ensure accuracy and appropriateness. Then there's the WHO 4-symptom screen, or W4SS. This involves checking if the patient has any one of these symptoms: cough, fever, night sweats, or weight loss. It's a simple yet effective tool that should be performed at every health visit to catch potential issues early. Finally, let's discuss C-reactive protein, or CRP. This is a general marker of inflammation, and it can be used as a point-of-care test. What's valuable about CRP is that it increases the specificity of screening, particularly for those who haven't yet started ART. For adults and adolescents over 10 years living with HIV, these tools, rapid molecular tests, chest X-ray with CAD, W4SS, and CRP, are all part of our recommended strategy for effective screening. They help us detect and manage HIV more efficiently, ultimately improving patient care and outcomes. On this slide, we're focusing on key tools for screening children for TB. First, symptom screening is essential. Look out for signs like cough, fever, weight loss or lack of weight gain, and reduced playfulness. These are common indicators that a child might be infected, so actively asking about these symptoms is crucial. Next, consider if the child has had contact with a TB patient. This exposure significantly raises the risk, so identifying contact history helps us decide on further testing or intervention. We also use chest X-rays as a diagnostic tool, especially when symptoms or contact history suggest TB. For children living with HIV, particularly those aged 10 years or younger, screening becomes even more critical because their immune systems may not show typical signs. The same applies for children who are contacts of TB patients, especially those up to 15 years old. The overall goal here is to use these tools, symptom screening, contact history, and chest X-ray, to identify potential TB cases early. This early detection is vital for timely treatment and better outcomes, aligning with our broader focus on effective TB control in children. Today, I want to highlight some important updates in our approach to TB screening and diagnosis. We have adopted all the latest global recommendations, specifically the 8th edition of the National TB-LLD Guidelines released in 2024. These guidelines reflect the newest evidence and best practices worldwide. One key change is the emphasis on chest X-ray, or CXR, as the primary screening tool for high-risk groups, including people living with HIV. Using CXR as the frontline screening method helps us identify potential TB cases more accurately and quickly among those most vulnerable. Additionally, we now recommend CAD software, computer-aided detection, as the preferred tool over human readers. This technology enhances consistency and efficiency in interpreting chest X-rays, especially in settings with limited radiology expertise. Another important update is the adoption of a negative sequential screening strategy, which is specifically recommended for use in Ethiopia. This approach involves initial screening followed by a second step if needed, helping to reduce false positives and improve overall diagnostic accuracy. All of these policy changes aim to strengthen our TB screening tools and ensure that we are aligned with the latest international standards. By integrating these updates, we can improve early detection, streamline workflows, and ultimately save more lives. Let's talk about the primary role of chest X-rays in TB screening. They are especially useful for identifying TB in asymptomatic individuals who are at high risk, such as household contacts, people in congregate settings, or those with comorbidities and immune-suppressive conditions. In these groups, early detection can make a significant difference. Chest X-rays also come into play when patients can't produce sputum samples, or when bacteriological results are negative, but we still suspect TB. They are valuable for diagnosing extrapulmonary TB, like pleural or pericardial TB, where the infection is outside the lungs but still needs to be identified. Furthermore, X-rays help us identify complications of TB disease, such as fibrosis or pneumothorax. Recognizing these issues is important for managing and treating the patient effectively. They are also instrumental in diagnosing other lung conditions that might coexist with TB, like bronchiectasis or lung abscesses. This comprehensive view helps us get a clearer picture of the patient's overall lung health. In the context of Ethiopia, the use of chest X-ray is particularly important as a diagnostic tool for TB. It helps us screen high-risk groups, confirm diagnoses, assess complications, and identify other lung diseases, making it a vital part of our TB control efforts. Let's discuss the use of CAD software-assisted CXR systems, which are increasingly preferred as the primary screening tool for TB, especially among individuals at high risk. These systems can effectively replace a human reader for screening and triage, streamlining the pathway to detect TB more efficiently. The main goal here is to determine whether an individual should undergo confirmatory bacteriological diagnostic tests based on the screening results. It's important to note that the use of CAD software with chest X-rays is particularly recommended for patients over 15 years of age. Additionally, this approach is valuable when evaluating individuals with presumptive extrapulmonary TB cases, as it helps in assessing for concomitant pulmonary TB disease. For those with abnormal CXR findings that suggest TB, further evaluation with WHO-recommended diagnostic testing, or WRD testing, is advised. In summary, the recommendations for using CAD-assisted CXR emphasize its role in effective screening and triage, making the process faster and more accessible, especially in high-burden settings. This approach aligns with our overall goal of improving early detection and treatment of TB. Let's take a closer look at positive sequential screening. In this approach, we start with 2 screening tests. The key point here is that only those individuals who test positive on the first test proceed to a second screening. And then, to move on to confirmatory diagnostic tests, a person must test positive on both screens. This method helps us increase the specificity of our screening process, reducing false positives and ensuring that only those most likely to have the condition are referred for further testing. Now, shifting gears to negative sequential screening. In this case, we also use 2 screening tests, but the flow is a bit different. If someone tests positive on the first test, they go straight for a diagnostic evaluation, which makes sense because their initial result suggests they might have the condition. But if they test negative on the first test, they then go on to a second screening. The critical point here is that if they test positive on either of these screens, they will be referred for diagnosis. This approach aims to catch as many true positives as possible, minimizing missed cases by allowing a second chance to identify potential issues. Both of these algorithms, positive and negative sequential screening, are designed to balance sensitivity and specificity differently, depending on the context and the goals of the screening program. Overall, understanding these strategies is essential as they form the backbone of effective screening protocols, ensuring we identify individuals who truly need further evaluation while minimizing unnecessary testing for others. This ties back to our overall theme of optimizing early detection and improving outcomes through strategic screening methods. Let's take a closer look at parallel screening. This approach focuses on screening for TB using 2 methods at the same time, or in parallel. For example, you might check for symptoms and do a chest X-ray simultaneously. The idea here is to increase the likelihood of catching cases early by not relying on just one method. If either screening shows a positive or abnormal result, meaning symptoms are present or the X-ray indicates possible TB, that's an indication to move forward with confirmatory bacteriologic diagnostic tests. It's a way to ensure that we don't miss cases by relying on a single screening method, and it can be especially useful in high-risk populations. This approach ties into the overall theme of optimizing early detection, which is crucial in controlling TB transmission and improving patient outcomes. Today, I will walk you through the recommended chest X-ray screening approach for tuberculosis in Ethiopia, which uses a negative sequential CXR screening algorithm. The process starts with symptom screening for everyone. If someone has positive symptoms, they are directly referred for bacteriologic testing, such as sputum analysis. For those who have negative symptoms, we don't stop there. Instead, we focus on high-risk groups for TB. These groups undergo a second level of screening using chest X-rays. If their CXR shows abnormalities suggestive of TB, they are then evaluated further with molecular WHO-recommended diagnostic tests. In certain community-based mass screening campaigns, we might use a parallel screening approach. That means screening individuals both with symptoms and with A-assisted CXR at the same time. Anyone who tests positive on either method will then need to undergo bacteriologic confirmation with molecular tests. This combination of strategies, especially the A-assisted CXR, aims to improve early detection and streamline our efforts to find TB cases efficiently across different settings in Ethiopia. This slide doesn't contain enough information. That's why we're moving to the next slide. Now, let's take a closer look at the high-risk groups for tuberculosis. These are the populations that are more vulnerable to developing TB, and understanding who they are helps us target our efforts more effectively. First, household contacts of TB or drug-resistant TB cases are at increased risk because of close and prolonged exposure. This includes children, who are particularly susceptible. Next, people living in urban slums face many challenges like overcrowding and poor sanitation, which facilitate the spread of TB. Prisoners are another high-risk group due to cramped conditions and limited access to health care. Health workers are also at risk because they often encounter TB patients during their work. Similarly, people residing or working in congregate settings, places where many people gather, are more exposed to infection. People living with HIV or PLHIV are especially vulnerable because their immune systems are compromised. Undernutrition and diabetes also weaken immunity, increasing the risk of developing active TB. Lifestyle factors matter too. Those who smoke or use alcohol harmfully are at higher risk. Age is another factor. Individuals over 65 have a higher susceptibility due to weaker immune defenses. Vulnerable populations such as refugees, returnees, pastoralist communities, internally displaced persons, and homeless or street families face additional hurdles like limited access to health care and living conditions that favor transmission. All of these groups are critical to identify because targeted screening and intervention can significantly improve outcomes. Now, moving on to diagnostic algorithms. This is where we focus on the tools and pathways to accurately detect TB early, especially among these high-risk groups. AI-powered CXR systems leverage deep learning algorithms to interpret chest X-rays quickly and accurately. These systems can provide probability scores not only for pulmonary TB, but also for other abnormal findings that might be present. The solutions endorsed by WHO offer automated interpretation, which includes localization of findings, so we can see exactly where the issues are, as well as TB scoring to assess the severity. They also have the capability to integrate seamlessly with picture archiving and communication systems, or PACS, and other health information systems, making data sharing and management more efficient. The portable AI-mounted CXR platform is designed to be versatile and user-friendly. It includes an X-ray tube and an exposure button for easy operation, along with a viewing computer or console for immediate image review. There's also a detachable sensor, which is useful for flexibility in different settings, plus connection cables and LAN for data transfer. The system is mounted on a tripod or stand, which stabilizes the equipment during imaging, and it comes with personal protective gear and safety equipment to ensure operator safety. When we look at the key features of these AACXR tools, rapid image analysis stands out. It can process and analyze images within seconds, which is crucial in high-volume or urgent situations. They also generate heat maps and bounding boxes that highlight abnormalities directly on the images, helping radiologists and clinicians quickly identify areas of concern. Additionally, these systems can classify findings, distinguishing between conditions like TB, fibrosis, or consolidation, which streamlines diagnosis. Importantly, they are designed to integrate with both digital X-ray machines and mobile X-ray units, providing flexibility in various clinical environments. Overall, these AACXR systems represent a significant advancement in diagnostic imaging, enabling faster, more accurate, and more accessible chest X-ray interpretation, which is a vital part of our efforts to improve TB detection and overall lung health management. When we talk about classification in AI, we're referring to the system's ability to categorize images into predefined groups. For example, it might determine whether an abnormality is present or absent, identify the specific type of abnormality, or even predict how a patient might respond to a particular treatment. This helps clinicians make more informed decisions quickly. Detection, on the other hand, involves pinpointing the exact locations of points of interest within an image. The AI outputs these as points, regions, or bounding boxes, making it easier to identify where something is happening. Think of it as the AI's way of highlighting the most critical areas that need attention. Segmentation takes this a step further by outlining abnormalities with pixel-level precision. This detailed delineation is especially useful when planning complex procedures like virtual surgery or radiation therapy, where understanding the exact surface of an abnormality is crucial. These different AI capabilities, classification, detection, and segmentation, each serve unique roles but all aim to enhance diagnostic accuracy and treatment planning. Together, they illustrate the powerful ways AI is transforming medical diagnostics by providing more precise, rapid, and actionable insights. Let's take a look at the different connectivity options available. We have offline, online, and hybrid solutions. When we talk about internet connectivity and hardware requirements, it's important to understand how each option impacts your setup. Online options typically require a stable internet connection and compatible hardware to access cloud-based platforms or real-time data. Offline options, on the other hand, are designed to work without an internet connection, relying on local hardware and storage. Hybrid options combine both approaches, allowing you to switch between online and offline modes depending on your needs. This flexibility can be especially useful in environments where internet access is unreliable or intermittent. Ultimately, choosing the right setup depends on your specific requirements, budget, and the environment in which you'll be operating. Understanding these options helps ensure you select the most effective and reliable solution for your situation. Now, let's look at how the image import process works in our AI-powered TB detection system. The technology accepts chest X-ray images in the DICOM format, which is the standard widely used in medical imaging. This ensures compatibility and seamless communication between different imaging devices. For some systems, it's also possible to import images in JPEG and PNG formats, giving us flexibility depending on the available data. Once the image is imported, the AI system takes over and performs an automated analysis. It uses advanced algorithms to examine the shape, symmetry, and texture of the lungs. This helps it identify any areas that might look abnormal, which could indicate the presence of TB or other issues. Next, the system generates a heat map that visually highlights these potentially abnormal areas. This makes it easier for healthcare professionals to quickly focus on critical zones. Alongside the heat map, it provides a likelihood score between 0 and 100, which indicates how probable it is that the X-ray shows signs of TB. One of the key benefits here is time savings. This automated process can analyze and produce a detailed assessment in less than a minute. It delivers a quality report, heat map, and likelihood score that can aid clinicians in making faster, more informed decisions. Overall, this image import and analysis process is central to how AI is transforming TB detection, making it quicker, more accurate, and more accessible for healthcare providers worldwide. Now, let's talk about the different AI systems used for TB detection and how they might produce varying outputs after analyzing a chest X-ray. These software systems don't all give the same results, which is an important point to keep in mind. When the detection software analyzes an X-ray, it typically provides several key outputs. First, it gives a quality assessment of the input image, helping us understand if the X-ray is clear enough for accurate analysis. Second, it generates a heat map that highlights areas in the lungs where abnormalities might be present. This visual aid can be very helpful for clinicians. Finally, and perhaps most importantly, the software provides a score indicating the likelihood that the X-ray shows signs of TB. This score can range from 0 to 100, or sometimes from 0 to 1, with higher scores meaning a greater chance of abnormality related to TB. Understanding these outputs, especially the confidence scores, is crucial because they help us interpret the AI's assessment. Remember, a higher score doesn't guarantee TB, but it does suggest a higher probability, guiding us toward further investigation or action. So, in essence, these AI tools offer valuable insights, but it's important to consider their outputs collectively, image quality, heat maps, and scores, to make informed decisions in TB detection. Let's take a closer look at slide 23, which focuses on the heat map generated by our AI system. This heat map highlights areas in the chest X-ray that may be abnormal and could suggest TB-related lung issues. The intensity of the colors indicates how likely an abnormality is present. Darker areas mean a higher probability. Moving on to the findings, the AI report identifies specific abnormalities within the X-ray, such as infiltrates, cavities, or nodules, which are often associated with TB. Each of these findings is clearly labeled and marked on the image, making it easier for clinicians to interpret. Next, we see the confidence scores assigned to each finding. These scores range from 0 to 100 and represent the AI's estimate of how likely that particular abnormality is related to TB. The higher the score, the greater the confidence that the finding is TB-related. The software then provides a simple dichotomized classification, either yes, indicating that abnormalities suggestive of TB are present, or no, meaning they are not. This decision is based on an overall abnormality score, which reflects the likelihood of TB being present according to the AI. Finally, the overall assessment consolidates all these findings and confidence scores to give healthcare professionals a clear picture. This helps guide diagnostic decisions and informs the next steps in patient management. Remember, these tools are designed to support, not replace, clinical judgment, and understanding these outputs is key to making informed decisions. Let's take a closer look at this CAD output example. As you can see here, the image illustrates what a typical CAD file might look like after the design process. The key points to focus on are the clarity and precision of the drawings. These outputs are crucial because they serve as the detailed instructions for manufacturing or fabrication. Notice how the dimensions and annotations are clearly marked, which helps in avoiding misunderstandings during production. This example highlights the importance of accuracy in CAD outputs, because even small errors can lead to significant issues down the line. By understanding this, we see how CAD outputs play a vital role in bridging the gap between design and manufacturing, ensuring that the final product aligns with the initial concept and specifications. This example underscores the central theme of the presentation: the significance of precise digital tools in modern engineering and manufacturing workflows. Now let's take a closer look at this heat map generated by CAD. As you can see, it visually represents areas of risk or concern within the system. The colors indicate different levels of severity, helping us quickly identify hotspots that may need attention. Next to it, we have the CAD score, which is a numerical summary derived from this heat map. It essentially quantifies the overall risk level, making it easier to compare across different systems or time periods. What's important to understand here is that this visual and the score together give us a comprehensive picture. The heat map shows us where the issues are, while the score gives us a quick, digestible overall assessment. This is a key part of our approach because it allows for targeted interventions, focusing resources on the areas that need it most, ultimately helping us improve system safety and reliability. Some CAD products are designed to give us a simple yes or no answer when it comes to TB-related abnormalities. They provide a binary classification, meaning they tell us whether abnormalities are present or absent. This can be really helpful in quickly streamlining the diagnostic process. The outputs from these CAD systems essentially categorize the findings into two clear groups, which makes interpretation straightforward. However, it's important to remember that while this binary approach is efficient, it might not capture all the nuances of each case. Overall, these tools are valuable for supporting decision-making, especially in high-volume screening scenarios, and they connect to our broader goal of improving accuracy and efficiency in TB detection. Now, let's look at how CAD software functions as an image classification tool. Essentially, they analyze chest X-rays to identify abnormalities that could suggest tuberculosis. Based on this analysis, the software assigns a score, which can range from 0 to 1, or sometimes from 0 to 100. This score reflects the likelihood that the X-ray shows signs of TB. The output is continuous, meaning that a higher score indicates a greater probability that the image is TB suggestive. But it's important to understand that these scores aren't necessarily directly proportional to the actual probability of TB. They're not linear, and different CAD products might standardize or interpret these scores differently. Also, the scores are independent of the prevalence of TB in the population. So, for example, a score of 0.4 doesn't mean it's twice as likely to have TB compared to a score of 0.2. Or, a score of 0.5 from one CAD algorithm isn't necessarily equivalent to a 0.5 from another. This highlights the importance of understanding what these scores mean and how to interpret them within the context of different tools and settings. Now, let's look at how we interpret these findings based on their confidence or probability scores. When we see a high confidence score, typically between 80 and 100, or a high probability from 0.8 to 1, this indicates a strong likelihood that the abnormality we're seeing is related to TB. These cases usually warrant further diagnostic testing and possibly starting treatment promptly. Moving on, findings with a moderate confidence score, between 50 and 79, or a probability from 0.5 to 0.79, suggest a moderate chance of TB-related abnormalities. In such situations, healthcare professionals should consider additional tests and clinical evaluation to confirm the diagnosis before making any final decisions. Lastly, when the confidence score is low, below 50, or a probability between 0 and 0.49, it indicates a lower likelihood of TB involvement. These findings might need further evaluation and should be correlated with the patient's clinical information to determine whether additional testing is necessary or if other causes could explain the findings. So overall, these scores help us gauge how confident we can be about the presence of TB-related issues and guide our next steps in diagnosis and management. The abnormality score is a continuous numerical output, which means it can take any value between 0 and 1. To make a clear decision about whether TB is present or not, we choose a cutoff point on this score. This cutoff is essentially a threshold that separates what we consider normal from abnormal. If the score is above this threshold, we classify the chest X-ray as suggestive of TB. Conversely, if the score falls below the cutoff, we classify it as not suggestive of TB. We often refer to this threshold as the operating point, the cutoff, or the cut point. It's important to understand that different CAD software products are developed independently, and because of that, their neural networks are built differently. This leads to different distributions of abnormality scores across different software. Even within the same software, different versions can be constructed differently, which again results in varying score distributions. So there isn't a universal threshold score that works across all CAD tools or even across different versions from the same supplier. The AI system analyzes chest X-rays and generates an abnormality score ranging from 0 to 100%. But this score alone isn't enough to make a diagnosis. It needs to be interpreted relative to a threshold score. This process of turning a continuous score into a binary classification, either TB is suggested or not, is called dichotomization. It's a crucial step because it simplifies the decision-making process and helps clinicians interpret the results more straightforwardly. The threshold variability emanates from several key factors. First, the varied TB prevalence plays a significant role. Different countries and population groups have vastly different TB burdens, which means we often need to adjust thresholds to find the right balance between sensitivity and specificity. Next, diverse healthcare settings also influence threshold selection. Resource constraints, testing capacities, and diagnostic algorithms can vary widely from one setting to another, impacting how we choose the most appropriate threshold. Finally, evolving software versions are another factor to keep in mind. As AI systems are updated and improved, their performance characteristics change, which may lead to differences in the thresholds used. All of these elements, prevalence, healthcare infrastructure, and software updates, highlight the importance of tailoring the CAD threshold to the specific context, ensuring we optimize diagnostic accuracy while considering the overall goals of the screening or diagnostic process. Let's take a closer look at the relationship between theory and reality when it comes to threshold selection, as discussed by Cresswell and colleagues in their 2023 paper. In theory, choosing a threshold might seem straightforward, set a cutoff point that distinguishes between different levels of a variable or outcome. However, in practice, it's often much more complex. There are many factors that influence how thresholds are selected, such as the context of the study, the nature of the data, and even practical considerations like ease of measurement. Cresswell et al. Emphasize that while theoretical guidelines can provide a foundation, actual decision-making can be quite nuanced. This disconnect between theory and practice highlights the importance of critical thinking and contextual understanding. It's not just about applying a standard rule. It's about tailoring the threshold to fit the specific situation, ensuring it accurately reflects the underlying phenomena. Connecting this to our overall theme, it reminds us that rigorous methodology must be balanced with real-world applicability. Threshold selection isn't just a technical decision. It's a strategic one that can significantly impact the validity and usefulness of our findings. Let's take a closer look at this slide. First, I want to emphasize the importance of understanding the core concepts here. These points are crucial because they tie directly into the overall theme of our presentation. As we discuss these ideas, think about how they apply to real-world situations and the challenges we face. The key takeaway is that by grasping these fundamentals, we can better navigate the complexities involved. Remember, the goal is to connect these concepts to the bigger picture, helping us develop more effective strategies moving forward. Let's take a look at some country examples of CAD threshold settings for AI systems. Starting with Zambia, they haven't set a specific threshold yet, and there's no information available on validation. Moving to Nigeria, they use the CAD-4TB system, and their current threshold is 60, which is a change from their previous threshold of 40. This indicates they may be adjusting based on performance or context. In Pakistan, they use the Lunit Insight CXR, with a threshold set at 0.5, which is equivalent to 50, but again, there's no information on whether validation has been done. Similarly, Vietnam is using the same system but hasn't set a threshold yet. China, on the other hand, is using the Inferi Dr. Chest system, and they base their threshold on the manufacturer's recommendation, which suggests reliance on existing validation or calibration provided by the developer. They have conducted validation, as indicated by the Y in that column. Finally, Bangladesh uses both QXR and Doctorade systems, with a threshold set at 0.5 or 50. But again, there's no clear information about validation. Overall, these examples highlight the diversity in how countries approach setting and validating thresholds for AI diagnostic tools. Some rely on manufacturer guidance, others adjust based on local data, and some haven't yet set definitive thresholds. This underscores the importance of validation and context-specific calibration in implementing these systems effectively. When choosing the right threshold, it's all about finding a balance between a couple of key factors. First, there's specificity, which is about reducing false positives. If we set a higher threshold, we'll have fewer unnecessary confirmation tests, which is good for avoiding overtreatment. But on the flip side, that might mean we miss more people who actually have TB, which is a serious concern. Then there's sensitivity, which is about catching as many TB cases as possible. A lower threshold can help us identify more true cases, ensuring we don't miss those who need treatment. However, this also means more unnecessary testing, which can increase costs and strain resources. When we talk about CAD thresholds, it's really about finding that sweet spot, where we maximize detection without overburdening the system. It's a strategic decision that depends on the specific context and goals of our screening program, always aiming to improve overall effectiveness while being mindful of resources. Let's take a closer look at the table showing interim CAD thresholds in Ethiopia. First, we see that the testing is categorized into different settings. For example, in community screening of the general population, the CAD threshold is set at 70. When we apply this threshold, about 10% of these individuals will have a CAD score that meets or exceeds it, indicating potential issues. It's important to note that the majority of these cases are bacteriologically confirmed, which adds confidence to the screening process. The radiologist's review suggests that around 5% of cases might require further attention, highlighting the importance of combining CAD scores with expert review. Moving on to key populations, the threshold is slightly lower at 60. This adjustment helps to identify at-risk groups more effectively. Again, about 10% of these individuals will have scores above the threshold, with similar proportions in bacteriological confirmation and radiologist review. Finally, in health facility triage, the threshold remains at 60, but this setting applies regardless of the risk stratification. The same percentages hold here, emphasizing that CAD thresholds are adaptable depending on the setting, but maintain consistent performance metrics. Overall, these interim thresholds are designed to optimize detection while balancing resource use, and they are a crucial part of Ethiopia's strategy to improve TB diagnosis through targeted use of CAD technology. The AI-mounted CXR tool is designed to be used in both health facility and community screening settings, though they're typically placed at the respective facilities. It's important to note that these AACXR tools should be integrated seamlessly into the existing TB screening workflows. So, when an individual comes in and registers, eligible persons will undergo digital chest X-ray screening. The AI tool then provides an immediate interpretation of the X-ray and assigns a TB risk score. This quick feedback is crucial because it helps us make timely decisions. If a person's score is above a certain threshold, they are triaged for further diagnostic testing, usually with GeneXpert or other WHO-recommended rapid diagnostics that are currently in use here in Ethiopia. Overall, integrating AACXR systems into clinical decision-making enhances our ability to identify potential TB cases more efficiently, ensuring that those who need further testing get it promptly. This workflow not only improves accuracy, but also speeds up the pathway from screening to diagnosis, which is vital in controlling TB. Let's walk through the typical workflow involved in using AI-assisted CXR systems for TB detection. First, there's the registration process, where we prepare the patient or client and ensure we have their informed consent. This step is crucial for ethical and legal reasons. Next, We capture the chest X-ray image using a digital machine, which allows for quick and high-quality imaging. Once the image is taken, it is analyzed by the AI system, which interprets the scan and generates a TB score. This score helps us assess the likelihood of TB presence. Based on this score, we make triage decisions, determining whether the patient needs further testing or immediate treatment, using predefined threshold scores. If the triage indicates a high probability of TB, the patient then proceeds to confirmatory testing, and their results are linked to care pathways, ensuring they receive the appropriate treatment and follow-up. It's also critical that we capture all data from the AI interpretations systematically, either through standardized forms or directly integrated into systems like DHIS2 to maintain accurate records. Finally, maintaining clear referral and feedback loops with laboratories and TB clinics is essential. This ensures seamless communication, timely follow-up, and coordinated care. Integrating AACXR systems into clinical decision-making processes can significantly enhance efficiency and accuracy, but it requires thoughtful workflow design and strong connections between all parts of the health system. In the workflow for the general population, we start with a community awareness campaign led by village health leaders and health extension workers. Their role is to conduct educational sessions to inform the community about TB symptoms, how it spreads, and why early detection is so crucial. They also create awareness about the importance of chest X-rays for TB screening. Next, we need to predefine the location and identify the target population, including gathering their profiles to ensure we're focusing on those eligible for screening. This helps us organize efficient and targeted outreach. During screening, health workers use a standardized symptom screening questionnaire to assess individuals. They look out for key TB symptoms like a persistent cough or weight loss and identify high-risk individuals, such as those with prior TB exposure, for further testing. Those with symptoms or risk factors are referred for chest X-ray screening at designated community gathering points. The chest X-ray images are then captured and immediately analyzed by AI technology to interpret the results. The AI analysis determines whether the findings suggest TB. If the CAD score is 70 or higher, this indicates a high likelihood of TB, and we proceed with collecting a sputum sample for confirmatory bacteriological testing, ideally right on site. For individuals with a CAD score below 70 but showing symptoms, they are referred for clinical evaluation to rule out TB or other conditions. If the score is below 70 and they are asymptomatic, we provide education about TB and schedule future screenings. Finally, the AACXR screening workflow at the community level ensures we efficiently identify, refer, and manage individuals at risk, making the whole process more streamlined and effective in controlling TB. Let's walk through the workflow for identifying and managing TB in key affected populations at the community level. First, community awareness campaigns are essential, and these are typically led by village health leaders or health extension workers. They conduct educational sessions to inform the target population about TB symptoms, how TB is transmitted, and why early detection is so important. Once people are aware, the next step involves capturing chest X-ray images, or CXRs, and analyzing them immediately using AI technology. The AI system helps us interpret the images quickly to identify signs suggestive of TB. The AI analysis produces a CAD score, which reflects the likelihood of TB. A score of 60 or higher indicates a presumptive TB case. When we see a CAD score of 60 or more, we provide results to the individual and proceed with sputum sample collection for bacteriological testing, ideally right on site, to confirm the diagnosis. For those with signs of other chest conditions or abnormalities, we link them to the nearest health facility for further evaluation. If the CAD score is below 60, but the person is symptomatic, we refer them for a clinical evaluation to understand their symptoms better. Lastly, if someone has a CAD score below 60 and no symptoms, we focus on education and set up a schedule for future screenings. This workflow ensures we catch TB early, provide prompt care, and link people to appropriate health services efficiently. Let's take a closer look at the decision tree for TB screening and triaging using AI-mounted chest X-rays in community settings. This diagram illustrates how we can systematically identify and prioritize individuals for TB testing. The process begins with community screening, where the AI analyzes chest X-rays rapidly and accurately. Based on the AI's assessment, individuals are then triaged into different categories: those who likely have TB and need immediate follow-up, and those who are less likely to have TB but still require further testing. This decision tree is crucial because it helps streamline the screening process, making it more efficient and accessible, especially in resource-limited community settings. It ensures that we focus our attention and resources on those most at risk, which can significantly improve early detection rates. Overall, this approach exemplifies how integrating AI with portable imaging technology can enhance TB control efforts at the community level, aligning perfectly with our goal of expanding access to early, accurate diagnosis. Now, let's discuss the awareness campaign, which is led by the TB focal person and healthcare workers. Their role is crucial in conducting educational sessions to inform patients about TB symptoms, how TB is transmitted, and why early detection is so important. Education helps empower communities to seek help promptly. Next, we move to symptom screening using a standardized questionnaire. This tool helps us perform initial assessments focusing on key TB symptoms, such as a persistent cough or unexplained weight loss. If someone shows these signs, we identify them as potentially having TB and proceed with bacteriological confirmatory testing. For those individuals who screen negative but belong to high-risk groups, we conduct chest X-ray screening at a designated, safe space, like a private area, to ensure privacy and comfort. We then capture the CXR images and analyze them using AI technology. This AI analysis provides a report, and we look at the CAD score. If it's 60 or higher, it suggests a potential TB case. In that scenario, we inform the patient and collect a sputum sample for confirmatory bacteriological testing. If the CAD score is below 60, we focus on education and scheduling future screenings to monitor their health. For those diagnosed with TB, treatment is initiated according to national guidelines, ensuring patients start on the right therapy promptly. Throughout this process, it's vital to ensure we document everything: screening outcomes, CAD scores, presumptive and confirmed TB cases, tests conducted, and treatments started, so we can track progress and improve our efforts. Finally, the health facility triaging workflow helps us organize these steps efficiently, ensuring that each patient receives the appropriate evaluation and care at the right time, forming a seamless process from screening to treatment. Let's take a closer look at this decision tree for TB screening and triaging using AI-mounted chest X-ray in high-frequency settings. What we're seeing here is a structured approach that guides healthcare workers through the process of identifying potential TB cases efficiently. The tree starts with an initial AI assessment of the chest X-ray, which helps determine whether a patient should be further evaluated or not. If the AI indicates a high probability of TB, the next step involves confirmatory testing or immediate treatment options, depending on the protocols. Conversely, if the AI suggests a low likelihood, the patient can be reassured or monitored as needed. The beauty of this decision tree is that it standardizes decision-making, reduces reliance on manual interpretation, and speeds up the triaging process, especially in high-volume or resource-limited settings. It ensures that patients who need urgent care are identified promptly, while those at lower risk are managed appropriately, optimizing the overall TB control efforts. This approach aligns perfectly with our goal of leveraging AI to enhance diagnostic accuracy and streamline workflows in difficult environments. It's important to remember that the AI system we're discussing for TB detection is designed to support healthcare professionals, not replace them. When interpreting the findings and confidence scores provided by the AI, it's crucial to consider the broader clinical context, including the patient's medical history and other diagnostic tests. This integrated approach helps ensure we make accurate diagnoses and develop appropriate management plans. Additionally, healthcare workers must follow standard procedures when collecting samples for bacteriologic tests. Proper sample collection is essential, and it should be done in designated sputum collection areas or booths to maintain quality and safety. This workflow highlights how technology and proper procedures work together in our overall strategy to improve TB detection and patient outcomes. It is important to understand that combining AI-mounted CXR findings with clinical judgment and other diagnostic tests is key for effective screening and triage. When we integrate the AI system's results into clinical decision-making, we need to consider the outputs it provides and how they fit into the overall diagnostic picture. Remember, this AI tool is designed to support clinicians, not replace their expertise and judgment. The AI system for TB detection can be a valuable screening tool. It helps identify individuals who may have TB-related abnormalities in their chest X-rays, allowing us to prioritize patients for further testing and evaluation. This makes the process more efficient and targeted. However, it's crucial to interpret the AI findings within the broader clinical context. That means considering the patient's symptoms, risk factors, and other relevant information. Clinical judgment remains essential in making an accurate diagnosis and deciding on the best management plan. Another important aspect is evaluating the confidence scores that the AI system assigns to each finding. Higher confidence scores suggest a greater likelihood of TB-related abnormalities, but these scores should always be interpreted alongside other clinical data and diagnostic results to make well-informed decisions. In summary, integrating AI-mounted CXR results into clinical decision-making enhances our diagnostic capabilities, but it's vital to always contextualize these findings and rely on comprehensive clinical assessment. When using the AI system for TB detection, it's important to correlate its results with other diagnostic tests like sputum testing or molecular assays. This helps confirm the diagnosis and provides a more comprehensive understanding of the patient's condition. Relying solely on AI results isn't enough. These additional tests add valuable information and help validate what the AI system finds. Next, we need to consider population-specific triage thresholds. The optimal thresholds for the AI system can vary depending on the population being screened. Conducting pilot studies or operational research can help identify the most effective thresholds for your specific setting. Tailoring these thresholds ensures the screening process is both efficient and accurate. The AI system can also be a useful aid to clinicians. It helps interpret chest X-ray images more effectively and can serve as a standalone triage tool in systematic screening programs. Think of it as an additional resource that supports clinical judgment and decision-making. Finally, it's crucial to follow established guidelines. The AI system should be used in accordance with national protocols for TB screening and management. These guidelines provide a solid framework for diagnostic algorithms, treatment initiation, and patient follow-up, ensuring that the integration of AI aligns with best practices and standard care. Integrating AI-mounted chest X-ray results into clinical decision-making enhances our ability to detect and manage TB efficiently, but always within the context of these validated protocols and complementary tests. Now, let's talk about the next steps after initial AI screening. If the AI system for TB detection indicates abnormalities that suggest TB, it's crucial to conduct further diagnostic tests. These tests should follow the latest national TB diagnostic algorithms to ensure accuracy and consistency. Once a diagnosis of TB is confirmed, the next important step is to start appropriate anti-TB treatment, again aligned with national guidelines. This ensures that patients receive the most effective therapy based on current standards. In cases of infectious TB, contact tracing becomes a key component. According to national guidelines, we need to identify and screen household and close contacts. This helps us catch potential new cases early and prevent further transmission. Data management and reporting are also vital. Proper documentation of the AI results, diagnostic tests, treatment initiation, and follow-up ensures we have comprehensive records. This not only supports individual patient care, but also strengthens our overall TB surveillance efforts. Healthcare facilities should always adhere to established national protocols for data management and reporting. Consistency here is essential for monitoring progress and making informed program decisions. Finally, follow-up procedures and patient management are critical. Continuous monitoring helps ensure treatment adherence, manages side effects, and supports patients throughout their recovery. All these steps connect back to our overarching goal: effective, comprehensive TB control and ultimately, eradication. Let's talk about HF-based systematic screening. This approach targets specific high-risk groups for TB screening among people seeking care at health facilities. For example, individuals being treated for diabetes, people living with HIV, patients on chemotherapy, adult household contacts, those with organ transplants, patients with other lung diseases, and people on dialysis. These groups are at a higher risk, so focusing on them helps us identify cases early and prevent further transmission. Now, systematic screening isn't limited to health facilities alone. It also takes place outside in the community or in special settings like prisons, shelters for homeless people, mining sites, holy water sites, large industrial parks, refugee camps, and internally displaced persons camps. This approach is often called active case finding because it involves going outside traditional health services to find cases where they might otherwise be missed. To make this work effectively, we need a dedicated team. This team typically includes 1 or 2 general practitioners or trained health officers, nurses, a radiographer, a laboratory technician for sputum collection, a biomedical engineer, and a health extension worker. All these professionals work together, often utilizing AI-powered chest X-ray systems to streamline the screening process. Setting up and operating such a system requires careful planning. We must ensure the team is well-trained, the equipment is properly maintained, and the workflow is efficient. This integrated approach, combining targeted screening and community outreach, is vital in the broader effort to control and ultimately eliminate TB. Let's take a moment to look at the roles outlined in this table. First, we have the GP, HO, and clinical nurses. Their main responsibility is to ensure the overall coordination of the screening activity. This includes supervising the workflow, managing personnel, and addressing any challenges that might come up during the process. They also act as the focal points for communication, making sure that everyone on the team is aligned and that the activity runs smoothly and efficiently. An essential part of their role is verifying the readiness of the screening site, which involves checking that all the necessary materials and supplies listed in the checklist are available. When it comes to client interaction, they have a direct role. They conduct initial assessments by asking clients about any symptoms that could indicate TB. Based on what they find and following the established screening algorithm, they decide the next steps for each client. This could mean referring them for further diagnostic tests, such as sputum collection or X-rays. Moving on to the lab technicians and technologists, their key role is in the technical aspects. They are responsible for collecting sputum specimens, ensuring that the samples meet quality standards. They conduct the lab tests following standardized procedures to maintain accuracy and reliability. After testing, they share the results promptly with the team members involved in decision-making and treatment planning. This quick sharing is crucial for timely responses. Additionally, they are involved in setting up and operating the laboratory system, making sure everything functions smoothly and efficiently. Together, these roles form a coordinated effort that is vital for the success of our screening activities, ensuring that clients are accurately assessed and promptly managed. As a radiographer, My role is to ensure the effective and safe use of X-ray technology. This means I carefully select the best site for setting up the X-ray machines, considering factors like space requirements, the structural integrity of the building, and ensuring we meet all radiation safety regulations. It's crucial to choose the right location to maximize safety and efficiency. I also oversee the installation process, making sure that the equipment is set up correctly, following the manufacturer's guidelines and adhering to operational standards. Proper setup is key to ensuring the machinery functions correctly and safely. Radiation safety is a top priority. I implement strict protocols to protect patients, staff, and the environment from unnecessary exposure. This involves careful planning and continuous monitoring of safety practices. During X-ray examinations, I perform the procedures with precision, aiming for accurate imaging while keeping the patient comfortable and safe throughout. After the images are taken, I share diagnostic results, often generated with AI assistance, with the referring healthcare professionals to aid in diagnosis and treatment planning. Setting up and operating the system properly is essential for delivering high-quality care and ensuring everyone's safety. Now, let's take a closer look at the roles of the biomedical engineer in this process. Their main responsibility is overseeing the entire life cycle of the X-ray machine and its associated CAD software. This means they're involved from the very beginning, making sure everything is set up correctly and runs smoothly throughout its use. During the initial startup phase, for example, the engineer carefully configures the equipment, paying close attention to every detail to ensure optimal performance. They also continuously monitor how the machine is performing, checking that it operates efficiently and reliably. If any technical issues arise, they collaborate closely with radiographers and other medical personnel to troubleshoot and resolve problems quickly. Providing guidance on proper usage is a key part of their role, helping ensure the equipment is used safely and effectively. Another important aspect is managing the packing and transportation of the system. Whether during relocations or decommissioning, the engineer takes responsibility for disassembling the system carefully, safeguarding sensitive components, and handling everything properly to prevent any damage. Finally, they're involved in setting up and operating the system as needed, ensuring that each stage of its life cycle supports the overall goal of delivering accurate, safe, and efficient imaging. This comprehensive oversight is crucial for maintaining high standards in medical imaging and patient care. Now, let's take a closer look at the roles of health extension workers, or HEWs. These professionals are fundamental to our outreach efforts. They actively engage with the community, which is crucial for building trust and ensuring the success of our screening programs. Their role includes mobilizing the community. This means raising awareness through local networks, holding community meetings, and using targeted communication strategies to reach as many people as possible. HEWs also organize and maintain order during the screening process. This involves managing crowds, guiding individuals through registration and waiting areas, and making sure everyone is attended to in a systematic and timely manner. Their presence helps keep the process smooth and efficient, which is essential for reaching our health goals. In addition to logistical tasks, HEWs provide basic health education during these activities. They address common concerns and promote preventive health practices, empowering community members with knowledge to take charge of their health. Finally, setting up and operating the entire system is a key responsibility. This includes preparing the necessary materials, ensuring the environment is conducive for screening, and maintaining the flow of activities throughout the outreach. All these roles come together to make our screening efforts more effective and community-centered. Let's talk about radiation safety, starting with operator safety. It's essential that the room provides enough space so the operator can stand at least 2 meters away from the X-ray generating tube during procedures. This distance helps reduce the operator's exposure to radiation. Moving on to patient safety, the X-ray exposure area must be clearly restricted to prevent unnecessary exposure to secondary radiation. Only the operator and the patient undergoing screening should be within a 5-meter radius of the exposure zone. Additionally, we need to take extra precautions for vulnerable groups, specifically restricting access for pregnant women and children. When considering the safety of the general population, it's important to select a site that is away from residents or any occupied areas nearby. This minimizes the risk of radiation exposure to the broader community. Now, let's touch on patient privacy. To ensure comfort and confidentiality, it's best to use a dedicated room for X-ray screening. If that's not available, bringing a portable tent can create a private space on site. If even that isn't an option, then the screening area must be well demarcated so that patients are not visible to others, preserving their privacy. Finally, regarding the safe use of equipment, the location must have a stable, dry, and properly labeled ground. This ensures the X-ray machine can be securely installed, which is crucial for preventing damage and ensuring safety during use. When selecting the placement site, these criteria are vital. They help us maintain safety, privacy, and equipment integrity throughout the screening process. Now, let's discuss the room and infrastructure requirements for our X-ray screening area. First, cleanliness is essential. The room must be kept hygienic to ensure safety and proper operation. Adequate space is also crucial. There needs to be enough room for both the operator and the patient to move comfortably during the procedure, which helps maintain efficiency and patient comfort. Ventilation is another key factor. Having ample natural airflow reduces the risk of airborne diseases like tuberculosis. Proper lighting is necessary as well, to ensure the operator can see clearly and the patient remains comfortable throughout the process. Additionally, we need a dedicated setup for the control console, a secure table to place the X-ray controls safely. For patient convenience, providing a chair for patients to place their belongings is a simple but important touch. We also have to ensure that all adjacent rooms to the screening area are vacated during the procedure to prevent any distractions or interruptions. Reliable electric power is another advantage, as consistent power supply helps ensure smooth and efficient operation without interruptions. Moving on to community considerations, it's important to select an area that's community approved. Sites with religious significance, such as churches, mosques, or temples, should be avoided to maintain neutrality and inclusivity. We should also consider past trauma. Avoiding locations associated with previous distressing incidents helps create a positive environment. Convenience is vital, so choosing a location that's easily accessible for all participants encourages higher participation and ease of access. Lastly, safety cannot be overlooked. The site should be safe and secure for both staff and community members, with minimal risks of accidents or external hazards. Overall, these criteria help us select the best possible site for effective, safe, and community-friendly screening. When preparing for digital X-ray procedures, it's essential that the designated radiographer or trained health professional checks the X-ray machine thoroughly before turning it on. This means inspecting the equipment for any physical damage, such as cracks or loose parts, to ensure it's safe and functioning properly. It's also our responsibility to ensure that the exposure room and the X-ray machine are clean and free from any contamination. A clean environment not only helps maintain the equipment, but also protects both the patient and staff from infections. Following the manufacturer's instructions carefully when turning on the machine is crucial. These guidelines are there to ensure the machine operates correctly and safely, preventing any unnecessary issues or malfunctions. Once the machine is powered on, it's our obligation to warm it up and calibrate it every single day. Proper warm-up and calibration help maintain image quality and prolong the lifespan of the equipment, ensuring we get accurate results consistently. Remember, preparing the equipment and environment properly isn't just about safety and maintenance. It's about delivering the best possible care to our patients through reliable, high-quality imaging. When preparing to use the portable digital X-ray machine, the designated radiographer or trained health professional has some important responsibilities. First and foremost, it's essential to check the machine for any physical damage before turning it on. This helps ensure safety and proper function right from the start. Next, we need to make sure the machine is clean and free of any contamination. A clean machine not only maintains safety standards, but also helps produce clearer images. It's also important to follow the manufacturer's instructions closely when turning on the machine. These guidelines are designed to help us operate the equipment safely and effectively. Once the machine is on, the radiographer has the obligation to warm it up and calibrate it daily. This step is crucial for accurate imaging and to keep the machine in good working condition over time. Before starting any procedure, it's our responsibility to alert everyone else in the room and ask them to leave. We need to clarify the potential radiation hazard involved so that everyone is aware and can take appropriate precautions. These steps, checking the equipment, cleaning it, following operating instructions, warming up and calibrating, and ensuring safety by clearing the room, are all vital for a safe and effective imaging process. They connect to the overall goal of protecting both patients and staff while ensuring high-quality diagnostic images. When installing ultraportable X-ray machines, it's best to choose a specific room that allows us to enhance privacy and minimize radiation risks. Ensuring privacy is crucial, and it also helps reduce the chance of secondary radiation exposure to others nearby. To do this effectively, all occupants of that room, as well as anyone in adjacent rooms sharing a wall, need to be evicted by the radiographer. It's preferable to do this in secluded areas away from busy, crowded spaces, so we can control the environment and avoid interruptions. The space we select should have good natural ventilation and lighting. This not only keeps the environment comfortable, but also ensures safety during the procedure. I recommend installing the machine in a well-demarcated, open area, which makes it easier to manage and control. Before finalizing the placement, I always take measurements, about 5 meters in each direction from the X-ray tube, to define a safe zone. After measuring, I mark this area clearly with a visible demarcation, so everyone knows where it is and can stay clear during operations. Once we've determined the optimal location, it's important to post radiation safety warning signs. These signs should be in both the local language and the Ethiopian federal language to ensure everyone understands the warning and stays safe. Remember, preparing the equipment and environment properly is key to safe, effective imaging. Proper planning and clear communication help us protect both the individuals being examined and our healthcare professionals. When setting up the equipment, it's essential that I choose a level, dry, and clean area for the machine to be installed. This helps ensure safety and optimal operation. I also need to carefully follow the manufacturer's operating instructions to avoid any mishaps. Before starting any radiography procedure, I must warm up the X-ray generating tube and complete the daily calibration. Powering up the equipment properly is crucial for accurate results and to prevent damage. Additionally, before each outreach program, I need to verify that the power bank unit, control console, image receptor batteries, and the X-ray generating tube are fully charged. This guarantees that the equipment will function smoothly throughout the session. It's also very important to be cautious when connecting external devices. I should only use devices that are specifically dedicated for this machine to reduce the risk of introducing software viruses that could compromise the system. When conducting community screening or triage programs, I am obligated to bring all the necessary radiation protection equipment. Safety is a top priority, both for the patients and the team. Lastly, I need to ensure that the screening team has enough request papers and client registration forms available at all times. Proper preparation and organization are key to running an efficient and safe screening session. Let's take a closer look at this ultraportable X-ray system designed for open-air setup. What makes this particularly exciting is its portability. It's small and lightweight enough to be easily transported and set up almost anywhere. This flexibility is really a game changer, especially in situations where traditional X-ray systems might be too bulky or impractical. By allowing open-air operation, it enables quick deployment in various environments, whether it's a remote location, an emergency scene, or a field hospital. This setup not only improves accessibility, but also enhances safety and efficiency, reducing the need for complex infrastructure. Overall, this innovation aligns perfectly with our goal of making medical imaging more adaptable and accessible, no matter where it's needed. It really exemplifies how technology is evolving to meet the demands of diverse and dynamic healthcare settings. When we talk about chest radiography, it's important to remember that it involves exposure to ionizing radiation. While this is a useful diagnostic tool, it does carry a potential long-term risk of developing cancer. However, I want to emphasize that this risk is extremely low when the radiation levels are properly controlled. That's why adhering to national radiation safety regulations, such as those in Ethiopia, is absolutely essential. Following these guidelines helps us minimize the radiation dangers for patients, our staff, and the general public. These regulatory considerations are a critical part of ensuring that we use X-rays safely and effectively, protecting everyone involved while still providing the best possible care. So, always keep in mind that safety protocols are there to safeguard health while allowing us to make accurate diagnoses. When conducting an examination, it is essential that the door remains properly closed during each exposure to ensure safety. If you're performing an outdoor examination, you must take a proper measurement as advised by the authority at the time of inspection. This helps create a clear demarcation with radiation caution signs posted in the community's native language, ensuring everyone understands the potential risks. Radiographers are also required to wear badges with thermoluminescent dosimeters, or TLDs, and optically stimulated luminescent dosimeters, or OSLDs, properly at all times during service. These badges need to be read every 1 to 2 months to monitor the amount of radiation dose received, both shallow and deep doses, by the worker. To protect the mother and the fetus, pregnant women are not allowed inside the exposure room or the designated area. It's good practice to ask all women of reproductive age about any known pregnancies and to make them aware of the potential risks of unnecessary radiation exposure. For female radiographers and technologists, once pregnancy is confirmed and reported to their supervisor, immediate adjustments should be made to shift responsibilities to keep them away from ionizing radiation. Remember, the ALARA principle, as low as reasonably achievable, must be our standard. It's about minimizing exposure for both clients and staff, preventing overexposure or double exposure whenever possible. In the event of an accident, your priority is to save the patient by all means. All X-ray examinations should only be performed by qualified radiographers or radiology technologists to ensure proper safety and technique. Finally, keep in mind the regulatory considerations that guide our practices, ensuring we adhere to safety standards and protect everyone involved. Let's talk about positioning individuals to be examined. This step is crucial because how we position someone can significantly impact the accuracy and effectiveness of our assessment. It's important to consider the specific examination we're conducting and tailor the positioning accordingly. For example, some examinations require the person to be seated, while others might need them lying down or in a particular stance. By positioning individuals correctly, we not only facilitate better access to the area of interest, but also ensure their comfort and safety throughout the process. Remember, proper positioning can also help us observe the relevant areas more clearly and collect more reliable data. This concept ties into the overall theme of effective assessment, being intentional and strategic with our approach. So, always think about the purpose of the exam and choose the position that will give you the best view and the most accurate results. When we look at a well-exposed radiograph, we can actually see the thoracic spine and the gaps in the intervertebral discs quite faintly, but clearly enough to make out important structures. At the same time, the branching vessels passing through the heart are very clearly visible, which helps us assess the cardiovascular structures effectively. Now, if the radiograph is underexposed, things get a bit trickier. It becomes difficult to see through the heart and mediastinal outlines, which means we can't clearly identify the lung parenchyma in those regions. This can limit our ability to evaluate lung tissue properly. On the flip side, if the radiograph is overexposed, the film appears too black. This excessive exposure can obscure subtle findings, like small lung nodules or faint pulmonary parenchymal opacities, making them much harder to detect. Finally, after capturing the image, post-image processing and optimization are crucial. They help enhance the image quality, making sure we can interpret the radiograph accurately and confidently. Proper exposure and processing are essential for a reliable diagnosis, and connecting all these details to the bigger picture of patient care. Now let's talk about exposure, which is a crucial step after capturing your image. Once you've taken the shot, the next phase involves post-image processing and image optimization. This is where you can really enhance the visual quality of your photo, ensuring it aligns with your creative vision. Post-image processing includes adjustments like correcting exposure levels, contrast, and color balance to make your image look its best. It's about fine-tuning the details to bring out the true essence of the scene. Image optimization, on the other hand, focuses on preparing your image for its final use, whether that's for web, print, or social media. This involves reducing file size without sacrificing quality, so your images load quickly and look sharp across all platforms. Connecting this to our overall theme, proper exposure and thoughtful processing are vital because they directly influence the impact and clarity of your final image. Mastering these steps ensures your work stands out and communicates effectively. When a radiograph is positioned properly, you'll notice that the medial ends of the clavicles are evenly spaced from the spinous processes of the vertebral bodies. This symmetry essentially indicates that there's no patient rotation, which is crucial for accurate diagnosis. Although rotation can sometimes give a misleading impression on the image, it's important to remember that it doesn't always make the radiograph unreadable. After capturing the image, post-processing and optimization are key steps. These techniques help enhance the image quality, making it easier to interpret and ensuring we get the most accurate information possible. So, proper positioning combined with thoughtful image processing really supports our goal of accurate, reliable radiographic assessment. Let's talk about inspiratory effort. In healthy individuals, a full inspiration typically causes the diaphragm to project above the level of the 10th posterior ribs. When you see the diaphragm projecting near or above the 8th posterior ribs, it often indicates that lung volumes are abnormally low. This could be due to poor inspiratory effort or restrictive lung conditions. Low lung volumes tend to cause basilar vascular crowding and atelectasis, which can sometimes mimic interstitial lung disease or pneumonia at the lung bases. Additionally, these low lung volumes can create the visual appearance of cardiac enlargement on the radiograph. It's important to remember that each client's chest X-ray findings need to be carefully processed by the radiographer after capturing a high-quality image. Once processed, all radiographs should be properly labeled and sent daily through PACS to the National Data Server. This process ensures accurate diagnosis and data management, which is essential in providing thorough patient care and maintaining the overall quality of imaging. The CAD box is a computer system that can easily connect to any digital X-ray unit. The connection between these two systems is established through a DICOM connection, which can be set up via WAFI or LAN. Inside the CAD box, you'll find the CAD program and SQL database, often referred to as PACS, and a local web server. To ensure smooth operation, the digital X-ray unit, CAD box, and router are all configured with fixed IP addresses. Most of the configuration and installation tasks are handled by the suppliers, but I highly recommend having a biomedical engineer present during the process. This way, you can collaborate directly with the supplier's engineer to address any technical nuances. Finally, it's crucial to follow the connection and login procedures provided by the supplier exactly as instructed. Doing so ensures the software runs properly and that the entire system functions seamlessly within your clinical workflow. Let's talk about the input side of the CAD system. It receives digital X-ray images in various formats like DICOM, PNG, JPEG, or even digitized analog X-ray films. The system then uses artificial intelligence to analyze these images for signs of tuberculosis. What's great is that this process can be done with or without an internet connection, making it versatile for different settings. Now moving to the output. For each X-ray analyzed, CAD provides an abnormality score, which ranges from 0 to 1 or 0 to 100. A higher score indicates a higher likelihood of TB. Along with that, it generates a heat map that visually highlights where the abnormalities are detected on the image. Finally, on the user interface and navigation, these features are designed to be intuitive, helping healthcare workers easily interpret the results. The abnormality score and heat map work together to give a clear picture, supporting faster and more accurate decision-making. Overall, this system is a powerful tool to help improve TB detection and streamline diagnostic workflows. On this slide, we're focusing on the key data elements that should be collected on a monthly basis to monitor our TB screening efforts effectively. First, we look at the groups of participants or patients who are being screened or triaged, along with their results. It's important to track how many people we need to screen to catch cases early. We'll also record the total number of individuals who are eligible for chest X-ray and CAD screening, giving us a sense of our reach. Next, we note how many people are actually screened for TB using X-ray and CAD tools for diagnosis. From there, we look at how many clients screen positive based on these methods. Importantly, we also track how many of those screening positive clients go on to test with molecular tests. This helps confirm TB cases. Another key point is monitoring the number of clients diagnosed with TB among those who screened positive with X-ray and CAD. We also need to keep an eye on cases where clients are diagnosed with TB clinically, without bacteriological confirmation. These are important for understanding the full scope of our detection process. Moving on, we have to monitor the operation of our AI systems that analyze CXR images to improve TB detection. This includes tracking the total number of invalid results, which might indicate issues with the system, and the total number of error results for CAD, helping us identify areas for technical improvement. Finally, all this data feeds into our monitoring and evaluation for the AACXR systems. Collecting and analyzing these key data points regularly ensures we are improving our screening accuracy, optimizing resource use, and ultimately saving more lives through early detection and treatment of TB. Now, let's look at some key indicators for monitoring the performance of X-ray CAD systems in TB diagnosis. First, we need to track the percentage of people screened with X-ray CAD. This helps us understand how widely these systems are being utilized in our screening efforts. Next, we look at the percentage of people who screen positive with X-ray CAD for TB. This gives us insight into how effective the system is at identifying potential TB cases. Then, we consider the percentage of people diagnosed with molecular tests, such as XPERT, among those who were screened positive with X-ray and CAD. This step is crucial because it confirms the diagnosis and ensures we are accurately identifying TB cases. Finally, I want to emphasize the importance of monitoring and evaluation, or M&E, for the use of AI-powered CXR systems. Regular M&E helps us assess the accuracy, reliability, and overall impact of these technologies. By keeping a close eye on these key indicators, we can optimize TB screening programs, improve early detection, and ultimately save more lives. Let's talk about the evaluation of AI systems used for TB detection. To ensure these systems are effective, we need a solid evaluation framework. This includes clinical studies, which can be observational studies comparing the AI system's performance against standard diagnostic methods. It's important to see how well the AI performs in real-world settings. We also evaluate the economic impact, considering costs, time saved, and how patient outcomes improve with AI. This is often done through cost-effectiveness analyses to understand the broader value of deploying these systems. Additionally, we look at the broader public health impact, how the AI influences TB diagnosis rates, treatment initiation, and overall health outcomes in the community. Since impact can only be truly understood with a comparison, we introduce baseline data from before the AI systems using chest X-ray, or CXR, were implemented. This historical data helps us measure changes after deployment. Sites that adopt AI systems with CXR generally see a notable increase in the number of presumed or confirmed TB cases. To assess this properly, we need to collect and analyze data on the number of incident TB cases, both new and relapsed, during the reporting period after the AI is introduced. We also compare this with data from an equivalent period prior to AI deployment. This comparison allows us to see whether the AI is making a real difference. In terms of monitoring and evaluation, or M&E, for these AACXR systems, consistent data collection on incident TB cases is key. This helps us evaluate the true impact of AI on TB detection and improve our strategies moving forward. Now, let's talk about scheduled preventive maintenance and how it helps keep our equipment running at its best. Regular inspections are crucial. This means checking mechanical parts to catch any signs of wear early. We also assess electrical connections to ensure everything remains secure and functioning properly. Verifying software updates is just as important, as keeping the system current helps prevent glitches and enhances performance. And don't forget about lubrication of moving parts. Smooth operation depends on proper lubrication. Moving on to corrective maintenance, it's all about proper monitoring. Over time, components can wear out or deteriorate, which can impact both how well the machine performs and the accuracy of diagnoses. Recognizing these signs of wear is essential. Knowing when to replace or repair parts helps us maintain the highest standards of performance and patient safety. Finally, maintaining optimal performance also involves robust technical support and troubleshooting. When issues arise, quick and effective troubleshooting is key to minimizing downtime. Consistent support ensures that the equipment functions reliably, supporting our overall goal of delivering accurate, high-quality imaging. Let's talk about how to identify signs of wear and deterioration in X-ray machine components. X-ray machines are quite complex, involving mechanical, electrical, and electronic parts, all of which can wear down over time with regular use. Recognizing these signs early is key to maintaining optimal performance. For example, you might notice irregularities in image quality, such as artifacts or inconsistencies that shouldn't be there. Unusual noises during operation can also be a red flag, indicating mechanical stress or parts that are starting to fail. If you see changes in exposure settings that aren't reflected correctly in the images, that's another sign something might be off. Additionally, error messages or malfunctions displayed on the machine's screen can signal underlying issues. And don't forget to watch for inconsistent performance over consecutive scans. That can point to wear affecting the machine's reliability. Now, moving on to the components that might need replacing over time. The X-ray tube is essentially the heart of the machine. It's responsible for emitting the radiation we need for imaging. Over time, its efficiency can decrease, leading to poorer image quality. Detectors are another critical component. They capture the X-ray signals and directly impact the clarity and accuracy of the images. When detectors deteriorate, images can become distorted or inaccurate. Filters and collimators help control the radiation output, and as they degrade gradually, the precision of the images can be affected. Cables and connectors are constantly in motion and exposed to radiation, which can weaken them over time, impacting signal transmission. Lastly, the CAD box, if it's not handled properly or if the software isn't kept up to date, can suffer damage that hampers the software's performance. To keep everything running smoothly, it's vital to have a good technical support system and troubleshooting procedures in place. Regular checks and timely replacements can prevent costly downtime and ensure that your X-ray machine continues to deliver high-quality images reliably. Remember, Consistent maintenance is the key to maximizing the lifespan and performance of your equipment. When it comes to replacing components, using genuine and compatible spare parts is absolutely crucial. It helps ensure that the machine continues to perform at its best and that safety standards are maintained. I always recommend getting spare parts directly from the manufacturing company whenever possible. It's also important to buy from authorized suppliers or dealers recommended by the manufacturer. This way, you can be confident that you're getting quality parts that will fit and work correctly. When communicating with suppliers, make sure to provide accurate machine details, such as serial and model numbers. This helps ensure compatibility and prevents any issues down the line. Keeping good records is another key point. Document all replaced parts, including their serial numbers, installation dates, and supplier information. This not only helps with maintenance history, but also makes it easier to report and manage when the machine is out of service or needs repairs. Connecting this to our overall theme, sourcing the right parts and maintaining proper records are vital steps in maintaining optimal machine performance and safety. They help avoid unexpected breakdowns and support smooth troubleshooting and technical support when needed. Now, I'd like to draw your attention to this slide, which highlights some key partners and individuals involved in our efforts. As you can see, we have a diverse group of dedicated professionals from various organizations. On the left side, we have names like Tay Letta from TBLLD, MOH, and Getashu Aga from the same organization, showing strong leadership within the Ministry of Health. Also, Tadel Awoke and Alemiehu Teref, again from TBLLD, MOH, emphasizing the central role of the National TB Program. On the right, we see notable contributors from academic and international organizations, such as Dr. Kumlashu Abate from SBHMMC, and others like Dr. Asfawasan G. Johans from USAID ETBE MSH, and Juram Asnake from TBLLD, MOH. These partnerships are crucial for integrating research, policy, and implementation. We also recognize the involvement of Dr. Burhane Meskel Asefa from USAID ETBE MSH, and Dr. Miftah Mohammed from ICAP, which illustrates the collaborative effort among donor agencies, implementing partners and technical experts. Further, there are key individuals from USAID Ethiopia, like Dr. Yul Sukasi, who help coordinate and support these initiatives at the national level. At the bottom, I want to highlight the role of our partners and donors, including the Global Fund, USAID, Stop TB Partnership, CDC, WHO, and various technology groups. Their support and collaboration are vital to the success of our programs. Finally, this slide also serves as an acknowledgement of all these individuals and organizations who contribute their expertise, resources, and commitment to our shared goal of TB elimination. It's a testament to the strength that comes from working together across sectors and borders. Thank you so much for your attention today. I really appreciate your time and engagement throughout this presentation. I hope you've gained valuable insights and a clearer understanding of the key concepts we've discussed. Remember, the ideas we've explored are all about driving growth, fostering innovation, and building stronger connections, principles that can truly make a difference in your work. If you have any questions or want to continue the conversation, please don't hesitate to reach out. Once again, thank you.